Can you see the screen now? My PowerPoint?
Not yet, Prof.
Oh. Hello?
Yes, Doctor.
Going now meeting. No upcoming meeting today. Share screen.
Yeah.
Is everything okay, Doctor?
Yes. Assalamu alaikum. How can my presentation? Is it present now or should I go to the cover option?
Yes, you should present now. If
Present
you
now.
have already opened the folder.
I opened already the folder on the computer and I choose a window
Okay, so
or a Chrome tab.
you can choose
A window, yes.
a window, and yeah.
And then I choose the lecture.
You choose the folder that you already opened.
Yes. Is it appear now for you?
Not yet, Doctor.
The lecture ready in the Google Drive. I opened the Google Drive and it is there now.
Oh.
It needs some modification.
If you open the Google Drive, so the folder is not downloaded on your laptop, right, Doctor?
Do you need me to download it? And try
If you
to.
want to open,
I am opened it, so you need to download first.
if you want to open a window, you can download first. But if you want to open directly from the Google Drive, you can present a Chrome tab.
I can
Present now.
Sorry.
If you haven't downloaded the slide yet, you can present now, but choose the Chrome tab.
The contact?
Chrome tab.
The Chrome tab.
No, the Chrome. This is why I asked you. Good. So I will try to Chrome tab again. Yeah. This is my question before. Thank you. Meet. Zoom. I don't know what is the issue with this one. It is not available now. Only you and your colleagues. So maybe if I press Zoom here, present, join, schedule, share screen. You mean share screen?
May I share my screen first?
Oh Allah, share. Cannot share your screen, sorry. An error. Yeah, now I can, inshallah soon. A Chrome tab, okay. Mute my drive, infection, yeah. Alhamdulillah, done. Is it clear now?
Yes, Doctor.
Yes, Doctor. You can
Yes,
see.
Doctor. We can see.
Thank you. First, let us start by al-Kitab. بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين كنعبد وإياك نستعين Today we are going to discuss an important lecture about the neonatal infection and the sepsis. Okay? If you have any difficulty in hearing, just inform me, please. Otherwise, I advise all to turn off their microphone, please. Okay? Today we are speaking about important issue. Can you hear me or not?
Yes, we can, Doctor.
Yes.
Here.
Yes, Doctor.
Now, as I am trying to tell you, I didn't meet all of you before, but now the science is dependent on subspecialty. Before, there is a lot of general, and still there is a general, but even now there is consultant in general. Okay, pediatric, this is an important. There is family medicine like that. So now we need to think always about subspecialty that can fill the gap in our practice. And I think until we are able to fill this gap, we must put in our mind that our community and our even Ummah all needs to be subspecialized, not generalized. Today, I am just presenting the neonatal infection as a one marker which can be difference between the infection in different age. So if you are speaking about, now you can see the next slide. Is it clear? Okay. So, okay, so now we need to speak about what is the neonatal sepsis, what is the neonatal infection. So we can find here that the neonatal sepsis is a bacterial infection in the blood. But if it is just,
Doctor,
yes.
I am sorry. Can you open the slide in full presentation mode, Doctor?
In full presentation can be, but I think I was going to make it bigger for you for some time, but can, sure.
Thank you, Doctor.
You can click present at your top right screen.
Okay, meet. This one. Okay. Now.
Yes, it is full right now.
Good, good. So now the neonatal infection, it may be just a simple infection like candidiasis in the mouse, like something in the skin. But to set sepsis, we signify that the blood now is able to go to the bloodstream. And it is very dangerous because if bacteria or viral or fungal come to the bloodstream, it means it will circulate like any bus or coach, and it can get stopped at any part of the body, in the brain, in the heart, in the lung, in the kidney, anywhere, okay? And this is a very important, like immune compromised patient, and we consider the neonate as not immune competent enough. We are not said they are immune compromised, but they are not immune competent enough for that. We will try to get our goal today to speak about what is the early onset sepsis, which occur usually at the first 48 hours to 72 hours. What is the late onset? It will be after 72 hours until 1 month. What is the late? Sometimes the infection can be extended until 3 months, must be considered at some times. Okay. Another important thing, the importance of early diagnosis of the sepsis. Because I used to tell anyone working in some special unit like neonate, if you are not able to smell the infection, you can lose the baby soon. Okay? And of course, our investigations and our treatment will be included in our discussion. Okay. So you can see here that the neonatal sepsis, as we speak before, neonatal sepsis refer to bacteria in the blood. As I told you, it may be fungal, it may be another. The first difference between the neonates and the other age is the presentation. What is the presentation of infection? It is most probably non-specific sign and symptoms. Okay, but it can sometimes be focal, like it can like meningitis with clear convulsions and sign like that. It can be pneumonia. It can be bacteremia, which only blood. Sometimes it comes to the urine. Sometimes the infection can settle in the bone, and many times we saw a baby who cannot move his thigh, and we found at the end he has got osteomyelitis or septic arthritis. It can be sometimes a congenital infection, and we must know the congenital infection, which has its own presentation. Usually the baby will come with signs of general sepsis, but we can find rash in the body, we can find hepatomegaly, we can find eye changes, ear changes, cardiovascular change like rubella and like that. And most of the cases are IUGR. So if you find one of IUGR, okay, it is very important to consider looking for the skin for any rash, looking for the liver for any hepatomegaly, looking is there any eye abnormality or ear abnormality or cardiovascular defects. Don't forget the same like infant, clinical spectrum of sepsis can be just simple sepsis, can be severe sepsis. I think we study that and we can declare it again. It can be septic shock. That is the mean there is signs of hypotension and cardiac affection and the patient need inotropes like that. And it can progress to multi-organ failure, okay? And lastly, it can cause death. That is why the importance of concentrating. If you didn't smell sepsis early and try to intervene, it will rapidly progress and it can be very rapid within few hours to progress to severe, and then the child will start to get hypotension and other cardiac affection and got septic shock, and then it can end by multi-organ failure. You will find the kidney affected, the liver affection, the heart is affected, the circulatory is affected, even the brain is affected, and it will end by death. That's why it is very, very important to do early diagnosis. Can you understand this point, please? I need you to share with me.
Yes, Doctor.
Early diagnosis is the gold standard of your medical practice. Everyone can diagnose the thing if it became late and frank. But if you pick it early and intervene early, you will get the best result of the patient. When you go to the surgery, they told you you are just teaching every lady just to do a breast examination to get early diagnosis of breast cancer, because if you diagnose it early, the prognosis is very good, more than 90% will survive. But if you neglected and not diagnosed, it will get very low probability to survive. It is the same for cervical. It is the same for like meningitis. If you didn't diagnose meningitis early, you will see complicated meningitis, okay? If you didn't smell sepsis early, you will find it when the baby go to the shock, and then after that, he will go to multi-organ failure and either die or progress to crippled cerebral palsy. That is why, please take care and put your goal. The first lesson I need to see, inshallah, all of you are subspecialized and they can give benefit to your community. Our community is trying to help us as they can, and we must say thank you and try to fill any gap for subspecialty. The second thing, try to have a high index of suspicious and diagnose early. Don't be the one stay until everything is clear for everyone and then you catch the diagnosis. At the time, it may be the patient deteriorated. So neonatal sepsis is a clinical syndrome of systemic illness accompanied by bacteremia occurring in the first months of life, but late onset sepsis sometimes can occur up to 90 days. A risk factor, a lot of risk factor, either maternal, okay, the mother has GBS, the mother has premature rupture of membrane. The most important one is the chorioamnionitis, okay? All this for the early onset sepsis, especially if the mother got fever and UTI and chorioamnionitis. But after that, there is something very important for the late onset sepsis, which is the mechanical ventilation and iatrogenic. What is iatrogenic? Do you know? What is the iatrogenic problem? What is the health care infection?
Related bloodstream infection.
Yes, healthcare associated infection is the most common cause of problem of neonates. Just someone doesn't clean his hand, washing a hand completely sterile. Someone did a central line. I just need you to think. If someone is doing a central line, which is going to go directly to the central vessel, and the central line in neonate is not like infants and children, not like femoral internal jugular. No, it is usually through the umbilicus. Do you remember how many vessels do we have in the umbilicus? 3 vessels. Very good. 2 arteries and 1 vein. Remember that we have 3 vessels, 2 artery, which is small and circular and strong, and the second one, the third one, which is the vein, is patulous and widened. Okay, and we are using this one as a line for survival of the neonate. We are going to insert UVC, and it is very easy. But if you didn't make it under complete aseptic technique, you are going to push inside it either bacteria or viral or fungal. And now you are killing the baby, you are not giving benefits. The same, if we need recurrent assessment for the blood gases, we are going to insert UEC, and also must be under complete aseptic technique. So remember, please, this is another important lesson. Healthcare associated infection, which is known as nosocomial infection, is 100 times more common than the congenital infection. Okay, and in ICU is one of the highest incidence of sepsis. And at least in America, they got at least 12% has one or more of infection. And after that, we will see what will happen with the healthcare associated infection. Why? We speak before. If you have pneumonia, even in children, I have many classification. Yes. First classification, is it lobar or bronchopneumonia? Okay, aspiration pneumonia. But according to the other classification, is it viral or bacterial or TB or fungal or other classification of pneumonia? Is it community acquired or hospital acquired? If it is hospital acquired, it is more severe. Why? Because of this line, multi-organ resistance. Multi-organ resistance. And this is a most challenging one. Sometimes you need to shut down all the unit waiting for the infection to go, because if you are still admitting, you are still infecting in you one. Okay, just I'm asking you to refer some patient to one hospital. They say it is the unit there is closed because they got multi-drug resistant organisms. Okay, so please, this is the start. We need to prevent the infection of the mother, of the baby. Number 1, to educate the mother and investigate the mother and catch early infection, especially chorioamnionitis and other. And we need to teach any harm, because your harm for a fragile baby, it is either this or cerebral palsy and retardation. Okay? Incidence, you can read the incidence. Really, I'm trying to get the incidence of in Malaysia. I cannot find the definite number now, but at least in USA, they said it is 12%, 12 per 1,000, but the mortality of untreated sepsis or severe sepsis can be up to 50%. Morbidity, the morbidity can cause meningitis, which can occur in 1/3 of the sepsis. Why? We said that the organism now is circulating in the blood, and it can easily cross the blood-brain barrier and cause meningitis. Some races are known to have GBS, sorry for abbreviation. I told you before also to be far away from abbreviation, because GBS can be Guillain-Barré syndrome, can be GBS, can be many abbreviations. So at least we must know that the GBS, which is gram-positive streptococci, is one of the most famous for infection. Another point, the premature baby has increased incidence of sepsis about 3 to 10 times more than the term baby. Why? They are relatively, as I told you, relatively immune compromised with immune immaturity of the immune system and the decreased passage of a maternal antibody. This is very important. You are not allowed to tell the family he's immune compromised. No, he is considered relatively, or it is better to say the family his immune system is immature, and he doesn't get the antibody from the mother because he was delivered a bit early, and most of the antibody will occur at the last few weeks of pregnancy. So if he came early, he didn't pick it. And just illustrate to the mother that if the mother got any infection before, so her blood is full of immunity, and this immunity will go to the baby. If the baby delivered early, many of this he will miss it. So another lesson, you must be able to select your words while you are speaking with family, while you are presenting yourself. Because if you said your baby is immune compromised, they may think, does my baby have HIV or AIDS or like that? No, it will go deep. Okay? As we speak, if the baby is less than 1 kilogram, okay, usually the infection is very, very high. If the baby catches meningitis, the infection and other side effect will be very high, even in term baby. Is there any difference in sex? Yes. As I used to tell, also the male gender is unlucky in neonates. Okay? The incidence of bacterial sepsis and meningitis, especially gram-negative, is higher in male. That's why the prognosis in male in the ICU is worse than female. Just present to you what is going inside the immune system of the baby and his mother, and we can see before birth what is going and after birth what is going. Okay? And most of the baby need some time to come to their own, and at this area, which is the gap area, if he doesn't get enough antibody from the mother, so he can easily infect it. Neonatal infection by age. Again, if it occurs in the first 48 to 72 hours, it will be early onset. If it occurs after that, it will be late onset. Maternal and obstetric complication is very common in early sepsis. It is very common in and very frequent in prematurity. Manifestation usually multi-system, but for the late onset, it will be occur after 72 hours. Usually the infection, as I told you, it came from relatively in decreased immunity of the baby or iatrogenic problem, and it varies. It can come to any baby, and sometimes it is just focal, not systemic. Repeating ourselves sometimes needed, so the idea will be very clear. Early onset sepsis, usually the baby can get infection. Okay, sorry for this 1 week, it is only first 3 days. Okay, it is very important. And remember the importance of intact membrane. It is Allah subhanahu wa ta'ala put the baby in many cover, in many membrane. If this membrane rupture early, which we said premature rupture of membrane, what will happen? There is a chance that the microbe, even some commensals which present in the vaginal tract, in the vagina and the other part of the tract, can go up and infect the baby. That's why we put, if there is premature rupture of membrane more than 18 hours, you must consider it significant, especially if not covered by enough antibiotic. So you asking about premature rupture of membrane and the documentation is very important. Okay, the late onset usually after 3 days. It is not related to the maternal, but related to the external one. The congenital infection may be present at birth, as I told you before, and it has its own presentation. Is there any difference for pathogens? Yes. Early onset, at the top, it is GBS. Late onset, it is CONS. CONS, which is coagulase negative staph, which is the most common iatrogenic organism or healthcare associated infection. But we can get Escherichia coli in early onset, Listeria, which is related to using of milk and its products. Okay, can be some viruses, some also cons can come through the mother. Don't forget sexually transmitted disease, and we'll just put one slide for that. If the baby in the early got fulminant course with pneumonia, there is probability of 50% mortality. Late onset, we can get cons, we can get staph. Most of them are gram-negative. Escherichia coli, Klebsiella, Pseudomonas, Enterobacter, and Acinetobacter, which is a very famous neonate with multi-drug resistant Acinetobacter, and the other. It is low course and easy invading the meninges, and the mortality is less, but morbidity is more. GBS is very important. Before it was known as Agalactia. It is the most common organism associated with early onset sepsis. It is a gram-positive encapsulated bacteria. Many strains, okay, especially this, the most common strain is 54. Usually it is colonization of the GIT and the genital tract. That's why if the mother has infection, usually we are doing high vaginal swab, and sometimes they may need to do rectal swab to see if the baby is infected, especially if there is previous history in the previous pregnancy that the mother got infection. Okay, directly, as I said, it is non-specific, but signs of respiratory distress and the cardiovascular instability, meningitis, shock, and death can progress very rapidly. But the most important is that if you find a child with respiratory distress, we must rule out sepsis. Even it is better to cover him with prophylactic or elective antibiotic with broad spectrum like penicillin and gentamicin until 48 hours until we rule out any infection. We will discuss this after. Otherwise, if you left him, he can progress directly to cardiovascular instability, meningitis, and end-organ failure. Escherichia coli, you know, all of you, it is a gram-negative rod, also colonized in the urogenital tract and GIT. It is the second most common cause of neonatal sepsis in term, and the most common in very low birth weight. What is the very low birth weight? What is the normal weight?
Very low, less than 1 kilo.
Anyone can
Low less than 2.5.
yes. Very good. No, the normal weight it is less than 2.5. Until 1.5, it will start to be very very low birth weight. Okay, low birth weight is less than 2.5. Very low birth weight is less than 1.5, and if less than 1 kilo, some I said very low birth weight like that, or extreme low birth weight. And if less than 750, some call it is incredible birth weight. Very difficult, okay? Usually, gram-negative are very aggressive for the neonate and they can escape to the meninges. One of important signs is one important clinical investigation is the platelet count. Platelet count usually will drop with sepsis. And if you find the thrombocytopenia and you are able to rule out something known as transient thrombocytopenia, which occur in some cases like Down syndrome and the other, and rule out the sample was clotted or like that, which consumes the platelet, you must consider sepsis or other transmitted antibiotic from the mother. So please, beside concentrate in the platelet. Listeria monocytogenes, as you can see, it is facultative anaerobe with gram-positive bacteria. About 17% can catch it of the mother, especially if hiring milk like that. Okay, it can cause spontaneous abortion, stillbirth, respiratory distress, sepsis, meningitis, granulomatous slash. Okay, higher risk in a mother consumed raw milk or unpasteurized milk. Okay, so it is very important to get it in the history. What about milk? Are you getting milk, mom? Yes. Is it raw or you are boiling it, or pasteurized or unpasteurized? Also, do you have any cats? Because milk can transmit listeria and the cat can transmit
Toplas.
plasma. Thank you. Okay. Then if we came to late onset, we will find the cons, which is a type of Staphylococcus. One, it has also many strain, late onset infection, very low birth weight, okay? And after that, we can go Staph aureus itself. Colonization also in the skin and the mucous membrane. Formation of biofilm. It is very famous with biofilm, protected bacteria from an antibiotic. And it causes penetration and help to invade the immune system. What is MRSA?
Decilin resistant hepatitis.
Yeah, so you must know how many types of resistance. It will be started by MRSA, which also is a very bad prognostic. Sometimes it can to 28% of the bacteria, but it can cause a lot of complication. So please try to concentrate on that and remember this biofilm, because even if you are working with like in case of osteomyelitis, sometimes you are making the blood culture, sometimes you cannot get the results. But if the surgeon is going to do surgery and he can scratch the periosteum itself to go the biofilm there and see is it invading or not, it is very important. As you can see, it is trying to defend itself. Other gram-negative like E. coli, Klebsiella, Pseudomonas, Enterobacter, Citrobacter, okay, can cause up to 70% of this. How it can be transmitted? Hands of a health care worker, colonization of a GIT, contamination of TBN, contamination of a line, like even bladder catheterization. Pseudomonas has the highest mortality, and the Citrobacter can cause brain abscess in the neonates. Can you realize now what is our role? That's why I used to say, really, for me, I am trying to wash my hand for every break. Why? It is ibadah. Yes, and you must wash your hand before every patient because also it is ibadah. It will prevent infection. It can prevent COVID now. It can prevent other problem like gram-negative organism which can kill the baby. And you must intend that and know that Allah will give you double benefit, not only because you are washing your hand, because you are saving other. And in Islam, if the benefit is extended, it has a high reward from Allah. Candida infection. Candida infection is very important because it is the third leading cause of late onset sepsis in premature infants. Okay, usually it occurs in very low birth weight and after giving a prolonged course of antibiotic, especially if it is a broad spectrum. That's why to prevent this infection, you must, when you are going to start antibiotic, you must ask yourself when I am going to stop it. What is my plan? To give it for until 48 hours, we have many stations, or I am giving it for 5 days, or I am going to give it for 7 days, or 10 days, or 2 weeks, or 3 weeks, or up to 6 weeks. So there is every stage of this has its indication. It must be clear, please. And do remember, also that lack of enteral feeding, it will cause colonization of pathogenic bacteria inside the gut, which can invade also and go to the blood. So we are doing 2 or 3 things now. Please, sterilization of our hand and the complete aseptic technique, especially if we are putting a central line or even peripheral cannulation, because it will go directly to the blood. Number 2, try to stop the antibiotic as soon as you can if there is no more indication for prolonged. Number 3, try to start enteral feeding, even if it is a very small amount, even 1 ml every 6 hours in extreme preterm. It will help him. It will help to prevent colonization of pathogenic organisms. Candida albicans also and another non-albicans, it carry a very high mortality and neurodevelopmental delay. And it can disseminate in the blood and go to the brain, go to the kidney, go to the heart, and goes like thrombus. So it is very, very dangerous. That's why many units are giving prophylactic antifungal, whatever IV or oral. For early onset, you must rule out group B streptococci by high vaginal swab. Chorioamnitis is very important, especially if you can find foul smell during birth. And remember to send the swab, because the swab will tell you what is the organism which is the mother infected. Premature rupture of membrane, especially if it is more than 17 hours. Prolonged means more than 18 hours. Okay. UTI is very important. Sometimes you need to ask about the culture result of the UTI. Okay. Multiple pregnancy will precipitate preterm delivery. All these are associated factor or precipitating factor for early onset. Late onset, this is the first one, breaking the natural barrier, like skin and the mucous membrane. We are punctured many times. Okay, it is very dangerous. Okay, I put one catheter, UVC or UOC or even urinary, and leave it forever. No, you must ask yourself when I am going to get rid of it. Invasive procedure, okay, like intubation like central line can precipitate for that. Necrotizing enterocolitis, I will speak about that. It is just by its name, it is enterocolitis, which is infection of the colon, but it will cause necrosis of the gut. And at this situation, it may be the child needs to do open surgery to cut a pieces of the gut and make anastomosis while he is still very, very preterm or extreme preterm. Okay. Also now, they are advising to be a bit far away from using the H2 receptor as a regular, because it will change the gastric acidity and help the organism to grow. For preterm himself, there is susceptibility not from the situation that he is a preterm and the decreased passage of maternal immunoglobulin and immune function is not so mature. Transplacental can come through the virus or bacterial or torch screen. You must know what is torch, okay? Vertical can come usually bacterial and some viral. It came from the mother passage, can be GBS or Listeria or Chlamydia or Uroplasma or herpes. Very important to comment about herpes simplex, because if the mother has active herpes simplex lesion in the external genitalia, it is one indication to do cesarean, because most probably the baby upon delivery will catch the herpes simplex. The dangerous is that in many cases, if it's still in the skin, it can pass. But as I told you, in neonate, it will go directly to the brain and cause herpes simplex encephalitis, with a very bad prognosis, either death or morbidity. Horizontal one, okay, which is bacterial, which is nosocomial, come from the staph, can cause Klebsiella, staph, Pseudomonas, whatever. Many viral can affect, and don't forget the rubella and its presentation in the neonate, especially for hearing, for vision, for cardiac, for skin. Cytomegalovirus is a very important, as we have treatment for cytomegalovirus. Okay. Hepatitis, even if the mother have hepatitis, hepatitis B, you must give two things, the vaccine and the immunoglobulin. Okay. If the mother had varicella, you must also give the baby as soon as possible the VZIG, which is varicella zoster immunoglobulin. It is very important. Okay. You need to read all these types of infection, okay, either ascending, either transverse, or coming from other. Let us speak again about the clinical presentation. Our initial presentation is very important because it's imperative to begin treatment before the result of the culture are available. That's to say, if you must diagnose the infection clinically and start the treatment. Don't wait to confirm by blood culture or like that. If you feel the baby starts to behave as infection, give the first dose as soon as possible before 1 hour, please. Clinical signs and symptoms of sepsis are non-specific and have a wide differential diagnosis. Okay, it can be presented by some respiratory distress, like transient tachypnea of the newborn, but it can be infection, it can be metabolic, it can be cardiac, it can be CNS. All this can mimic infection. So we cannot rule. If you find the baby started to be in distress and other symptoms which we are speaking about now, non-specific infection like temperature instability. Usually, neonate will present it rarely, especially if extreme to good fever. Usually they will hypothermia or temperature instability. A change in the behavior, and this one is an important lesson for us. You must contact with the sister or the nurse in contact with the baby. If she tell you this, my patient behaves abnormal from his routine, you must take care. If he became to be bit lethargy and sleepy or irritable or a changing in his tone, take care. If you didn't pick him early, it is very dangerous. About the skin, if you found poor perfusion of the skin, even before starting to get prolonged capillary fill time, we have something known as mottling of the skin. It means the skin is like mottled. If good cyanosis, of course, mottling, pallor, peachy, rashes, or jaundice, all this is important. Sometimes the jaundice is secondary to infection, not other causes. If his baby started to have a feeding problem, like feeding intolerance, vomiting, abdominal distension, you must consider that. Cardiovascular also, if he started to get tachypnea, respiratory distress, it is 90% he can get infection. If you started to get grunting, flaring, retraction, apnea, is very, very dangerous. A cardiovascular system can sometimes get tachycardia or hypotension or bradycardia or pallor or mottling. All this can be signs of CNS or severe infection, cardiovascular with severe infection. Don't forget that sclerotic skin means that if you touch the skin of the baby, you will find it like woody like. It is very ominous sign, and it tell you, please, rapid and aggressive treatment is the only way to survive. Metabolic, many cases of sepsis will get abnormality in the blood glucose, okay, or metabolic acidosis, and you must take care about that, please. Okay. Of course, other hematological cases. Less common, but if it occur, it is ominous sign. If the child started to get convulsion, of the newborn baby started to get convulsion, it is ominous sign. It means either he has like metabolic, like hypoglycemia like that, or he got CNS infection. What is DIC? DIC is a latent symptoms which disseminated intravascular coagulation, and it is very critical one. If you started the child to get BTK, it is very ominous sign. If you started to find the hepatosplenomegaly or pathological jaundice, all this beside meningitis. Meningitis in neonate is a bit different. Patient will present by irritability and lethargy and poor response and abnormal neonatal reflexes, hypotonia, hyporeflexia, full fontanelle. Okay? And even his cry is sometimes a high-pitched cry, he can get convulsion and another. So please, it is not in the neonate to say about Kernig's and Brzezinski. Usually it is, unless there is some neck stiffness in obocytonus like that, but most of the time you must suspect by this manifestation. That's why I told you every age and every specialty has its own areas. The same message, but I try to tell you the infection can settle where. Is it, which one can affect every part of the body. You can see from the illustration. So if I found the baby who is extreme preterm or have risk of sepsis from mother wise and or he stay in the mechanical ventilator and the good ventilator associated pneumonia, yes? Ventilator associated pneumonia is different than before we used to call it ventilator induced pneumonia. But we find it is not related, it is not induced. The issue really, when we put the ET tube, it prevents the secretion to come out. not we are not causing. So they discuss the issue and feel that if we said ventilator-induced pneumonia, it means that we are attacking ourselves and we didn't do anything wrong. So they said it is ventilator-associated. Usually, when you put the ET tube with the ventilator, secretion will not come, it will stay inside, and even you cannot suck all because you have limitation for sucking and like that, and it can precipitate infection. So we are trying our best to extubate as early as possible, but sometimes it depends on the patient. We cannot extubate him. So came now to the conclusion that it is ventilator-associated pneumonia. In USA, I think it prevents a lot of medical-legal issue, because if you said someone by his language, ventilator-induced, I am the one, my ventilator is the one who induced, it is wrong one. Okay, so we need number one to consider blood culture, which is the gold standard. Number two, to remember that the positivity is very low in the intrapartum admission. So it is, if the patient are clinically, go ahead. Don't worry, because the blood culture will not 100%. Sometimes it came to only 40% like that. Okay. Another thing, which is blood. If consider meningitis, you need to do CSF. If you suspect urinary infection, you must go for urine UFME and urine culture. Okay, chest X-ray, of course, for any case of respiratory distress to rule out. I think you have another lecture about respiratory problems. Is it infection or it is another anomalies? What type of problem in the chest or other? If you suspect disseminated herpes, and it is very important, you must do mini culture, okay, from different part of the body to diagnose it, because as I told you, the herpes simplex have a very, very bad prognosis. History is very important, that the mother has any exposure or with during physical examination also to see if there any abnormality on the skin or catheter-induced problem. So number one is the culture, either aerobic or anaerobic. Blood culture result should be generally reveal the organism of the infection within 2 days, 48 hours. Subsequent initial identification of the organism, which will help you to choose your final treatment. You will start, we'll speak after that about coverage, but after the blood culture came to you, you must change your antibiotic into that one came from the culture. In neonate, it is enough to get from one culture, okay, for isolation of the bacteria. But I think it is better to be at least 1 centimeter. Urine culture, as you know, the standard for urine culture is suprapubic. If it is impossible or the family doesn't accept, we can do through the catheter. But urine collection is not informative, unless it came negative, we can say it is negative. Number two, the full blood count and the differential count, you must go through it and know it is very important. And please, every one of you must be ready with a clear article about how to read full blood counts. And I hope from the representative of the group to ask someone to do it for us, please. How to read a full blood count. Sometimes the serial monitoring will guide you about the infection, because you will find the platelet is dropping, white count is dropping. C-reactive protein is also informative, okay, and it is easy to done, and it's important for serial measures. If I found the trend is increasing, it means infection. But procalcitonin and the other marker like interleukin-6 sometimes is higher, superior for CRB, especially if you need to stop antibiotic. I mean, if you did procalcitonin and find it normalize, so it is specific for infection. But CRB sometimes can affect it by many issues. That's why you must know what is new in our era of diagnosis. CRB level is not recommended as a sole indication of neonatal sepsis, but may be used as a part of sepsis workup, as I told you, or as a serial study during the infection to assess the response of the antibiotic and determine the duration of the therapy. Other acute phase reactants is very important, as I told you. Coagulation profile must be considered if the patient has got any signs of either ecchymosis or bleeding. And usually we are doing BT, BTT, and one test known as FDB. FDB is fibrinogen degradation product, which is an important test for coagulopathy in the neonates. It looks informative like D-dimer. Sometimes we need to assess the immunoglobulin if we suspect the patient has problem with it. Lumbar puncture and the CSF, we'll discuss it during our skills, which is very important to comment about the marker of bacterial infection, which usually is increase the white count, especially in polymorph nuclear. But what is the normal for neonate? Normal for neonate can be up to 20. It is not like children. So we can accept up to 20 for neonates, okay? And some said for extreme preterm, you can accept up to 30 or 28 like that. So there is big difference also about the protein, about the glucose, about the other. I think you must establish an important table for the result of the CSF in different cases. Herpes simplex, okay, PCR is very important, okay. It is reserved for infant with CNS abnormality, skin vesicles, or CSF abnormality. However, vesicles are not present in as many as 1/3 of the CNS infection. This is very important. In many cases have CNS and the skin infection is very minimal, or sometimes it is not so clear. So sometimes we need to consider the herpes simplex infection. At least we can do with the torch screen. Torch screen is a test for congenital infection, which including IgM for herpes simplex. You can do it also. As I told you, for our investigation, please, we are dividing it into lab and RADs and bedside test sometimes and some specific. Okay, so we speak about the lab now. About the RAD, chest X-ray is very important. Sometimes we may need to go for CT or MRI, especially if we suspect complication like meningitis and others. Everything has its weight, its benefit, and its limitation and the requirement. Okay, but ultrasound is a gold standard. Just now we can do it real time, easy to detect if there is some sort of ventriculomegaly like that in case of meningitis or IVH. Bedside test sometimes is very important, which will consider the arterial blood gas to see if the baby has metabolic acidosis or not. What about his blood glucose? He has any hypoglycemia or hyperglycemia? It is very important for that. But the gold standard for diagnosis of infection will be the culture and sensitivity. After that, how can we manage or how to treat? The most important treatment is the prevention. And remember that, please. Before, we are waiting the patient to get infection and then we are treating. Nowadays, we are treating to give all vaccination just to prevent infection, which is very important. So try number one, to educate the mother and make antenatal care for every pregnant woman. And if you suspect or history of GBS or any infection, you must investigate and give treatment. Some are recommended GBS for all, and some recommended if she has symptoms or secretion or other manifestation. Okay, but take care because of chorioamnitis, and if it is present, the mother must be covered by antibiotic before delivery with a good coverage. Intrapartum prophylaxis with penicillin, ampicillin, or other must be considered at least 4 hours before. So the mother is very important. Then our role is to prevent hospital-acquired infection. Hand washing is very important, infection control, and we must restrict to infection control. Before, you will find some infection came because someone is not washing his hand good, even if he go to toilet or like that, or he came from outside and finish his eating and he need to go directly to the work with the baby. It is very dangerous. Proper placement and management of any central line, okay, and the hand hygiene. Usually, if we are going to in the ICU at the first, we are going to wash our hand if we are going to start, and if we eat or like that, it is better, or go to toilet, it is better to wash again. But between that, we can use hand rub between. Of course, if you are going to do any intervention, you must complete personal protective. That is to say, you are going to wear mask, you are going to wear gown and apron, and you are going to cover your head, and sometimes you need to cover your shoes at least, not to infect the baby. Before we have a lot of cases was discussed before, should I give IVIG? It is not proven, okay, efficacy. Should I give, but if the patient has like hepatitis or varicella zoster, there is specific one. Anti-staphylococcal monoclonal antibodies, okay, for encapsulated polysaccharide antigen and clumping factor A, okay, no effect in prevention of sepsis. But anti-lipoic acid antibody, very expensive, Boximab, this has an effect, okay. Granulocyte CSF, no proven efficacy. To give it to increase the white count. So they said it has no proven efficacy. Okay, also the same with, about speaking of probiotics, no proven efficacy in the neonatal, sepsis, usually as a prevention of NIC only. Lactoferrin, okay, you must go through it, but fluconazole is recommended by many units, and many units also recommended to give oral nystatin, especially if we are using antibiotic for a longer time. For management, as I told you, you must be able to smell sepsis early. If suspected neonatal sepsis, treatment should be immediately started after rapid sampling. I just collect the sample and start antibiotic directly without wait. Start antibiotic as soon as possible, and I advised to be in the first hour of age. Then it is very important to start start monitoring of the baby, because the baby can get hypotension and other complication. You must support cardiopulmonary if the patient has problem with respiration. Either give him oxygen. If not respond, you need to give non-invasive. If not respond, you may need to give him invasive mechanical ventilator. If not response, you can go to another like high frequency ventilation and that. Okay, blood product transfusion, like as indicated, temperature support and dextrose monitoring is an essential. What about the antibiotic? You must remember this one. Antibiotic is a very, very important weapon, but we must use it by judicious manner. Okay? Because if we open the use of antibiotic, it will cause multi-drug resistance. So don't use the antibiotic without limitation and you think you are giving a favor for the baby. No. Once you are sure the patient is clinically stable and there is no signs of sepsis and the culture result is negative, you can stop. Don't be afraid. Usually we are started by ampicillin and gentamicin as empiric one, but after the culture we must start. Remember that if you suspect some infection like listeria, you are going to use penicillin. Of course, low onset sepsis, if it is severe, you must consider vancomycin directly, which is the best cover for cones. Amphotericin B and fluconazole will be used as antifungal. It's very important. There is new antifungal which is a good now available in the market. So empiric initiation of antibiotic, then switch the antibiotic as based by the culture and sensitivity, and define the duration of the antibiotic. This is your goal for any patient you are doing with it. If you need, you can start the empiric antibiotic. If the culture came and they tell you that there is a better antibiotic that you are using, you must go for that. But you must ask yourself, for how long I am considering that? How much is the duration? Early onset sepsis without meningitis, it can be for up to 10 days. Late onset, it is from 10 to 14. Meningitis, it is 14 until 25 according to the organism. If gram-negative road meningitis, it needs at least 21 days. But for another sepsis, like osteomyelitis, it may need up to 6 weeks. This one is just to guide you the importance of congenital sepsis or congenital infection and to give you high index of suspicious in some circumstances. Okay? Transmission, if the mother has syphilis, the transmission rate is 90% if the mother has untreated primary or secondary infection. And any time of infection during pregnancy, she is infected. Clinically, it is asymptomatic in 60%, but you can catch after that hepatomegaly in most of the cases, skeletal abnormalities, osteitis and periosteitis, lymphadenitis, maculopapular rash, okay, which is contagious, rhinitis, snuffing, and anemia. All this thrombocytopenia, CSF changes can guide you for the congenital sepsis. But we need the formal test, which is RBB or Vidral, okay, which must be fourfold in the infant compared to the mother, okay, and re-rise. Another test is very important. Management is at least 10 to 14 days of aqueous penicillin. So it is very important. What can guide me? Can guide me the mother history. Okay, so you must consider history will help you a lot in taking a vital decision, please. Yalla, let us ask now who can answer, please. The first picture to the up left. Who can answer? Assalamu alaikum.
Candidiasis, Prof.
Yes. So, what is the significance of that?
Because there's the presence of thrush at the tongue.
Yes, if you found this thrush stomatitis, what you will tell the family?
Encourage enteral feeding.
Okay, so it is very important. In spite, it can happen as a part of immune deficiency like that, but we used to see it in many children. We need to teach the mother, okay, about how to prevent and treat, because usually the organism will be available if in breastfeed. We need to make sterilization of the nipple of the mother. If artificial, it can be easily infected and give the infection to the baby also. Okay, so advising the mother by hygiene and is very important. Okay, but as I told you, it need at least from 7 to 10 days to go, because many mothers are giving only for after 48 hours, it will start to disappear, but it will disappear from the surface, but still in the deeper area. If you cut, it will come again. So you must also know the duration of this antifungal. Okay? Who can comment on the up to the right, please? Up and right.
Impetigo, Prof.
Sorry?
Impetigo.
Not impetigo. This is the umbilicus.
Tonsillitis.
This is the umbilicus, yes.
Is it
Escrow.
enterocolitis?
No. What is there? This is the umbilicus. What is here?
Necrotizing.
No, it is very umbilical redness.
Respiration.
Yes, it means that there is infection here in the area of the umbilicus. And don't forget that the umbilicus contains the central vessels, which is going to the liver and the heart. So you must take it seriously if you found infection like this around the umbilicus. Usually we may indicate admission and getting a swab to know the organism and the blood culture and start the treatment. It is the same also for some cases. If you found in the nail of the tooth like that infection, you must take it seriously because it can find its way to the blood without limitation. Okay, so in spite it is local, it can spread very rapid to a neonatal sepsis. Okay, so the right lower, who can comment please?
Herpes simplex, Prof.
Is it like popular?
Sorry?
Oh, vesicular rash.
Yes,
Vesicular
very
rash.
important. As I told you, please, if you got any skin lesion, you must be able to define. Number one, what is the type of rash? Is it macule, bacule, maculopapular, vesicular? So it is vesicular or nodulum, so it is vesicular. How is the distribution? Number two.
Over the truncal area.
Yes.
Extending up to the back.
And there is some also in the limb and here. So what did you suspect now?
I think same as what Aklan said, herpes simplex virus.
Yeah. Now it is cutaneous. You must get it seriously if a newly arrived baby. And if you go to chicken even, which is this one doesn't look like a chicken pox, if you get chicken pox also, we must start very aggressive antiviral acyclovir like that, especially in the first few days after birth. Okay, to the lower left, who can comment?
I think there's a
Ventilator association pneumonia.
hypotonia of the.
Yes, good. He looks. He looks
hypotonic.
He looks flaccid. No, but usually this is due to our sedation. If the patient needs this type of care, you must give him sedation. Otherwise he will fight the ventilator, he will fight everything. So it is done by us. We give him midazolam, morphine, we give him fentanyl, like that. So what other manifestation, what other things you can see?
Patient was intubated and was getting under ventilator, probably pressure ventilation.
Okay.
And then was being under strict monitoring of cardiac monitoring.
Okay.
And there is a injection done. I don't know for what.
Catheter, Prof? Catheterization, multiple site?
Umbilical catheter.
Yes, central line. There is neonatal central line. Okay.
Yeah.
Good. What else? This is the 80 tube. What is this one? Okay, what is this one? Pulse oximeter, ECG. That is the care usually which is the patient with sepsis doesn't depict early. Usually he will end by that. He needs intubation, he needs some inotropes, he needs central line, he needs close monitoring, he needs a lot of issue. He needs complete sedation not to fight. And that is my lesson for you. Try to smell infection. Try to be the doctor who can diagnose the problem as early as he can. Okay? Please. Now, early onset sepsis and late onset sepsis. If I ask you one question, who will answer? So we just got one baby, okay, delivered to a mother who have history of gestational diabetes mellitus, okay, and she has recurrent UTI and one spike of fever and vaginal discharge, okay. Here, high vaginal swab give us the GBS. And unfortunately, the mother come to delivery on the spot without getting any antibiotic before. The baby just delivered, and you find the baby started to get the kidney and the grunting. What you will do?
Because there is a high suspicion of patient will be in sepsis. So for after within
What type of sepsis?
early onset sepsis.
Okay, yeah, try to be specified now. KFC here must be more specified, please.
So we need to treat the patient early within 1 hour of assessment. We need to start immediately the empirical antibiotic.
Before that, you need to?
We need to send to establish for blood cultures, which is the good standard.
Yes, before that we need to?
Secure the airway, breathing and circulation.
Yeah, the number one, stabilize the baby, while another stuff collecting the sample, and the third one is starting the antibiotic. That is why he is very young, but he needs a lot of job. He needs a lot of hands. Okay? So remember that your priority is to stabilize the baby, ABC like that, and at the same time, you are going to collect the sample while you are preparing the first dose of antibiotics. This is the gold standard, and put the baby under complete monitoring. You will monitoring the respiratory, you will monitoring the cardiovascular, you will monitor the CNS, you will monitor the hematology, you will every urinary output. What about the stool? What about the chest X-ray? So you need to make monitoring of all system to pick any multi-organ failure or septic shock. Is it clear?
Yes, Doctor.
Yes, yes, Prof.
Who will answer the question about late onset sepsis? Who will be? I need one candidate to answer my question.
Okay, let me try it.
Okay. Now we have mother really is delivered her extreme preterm baby who is just 1,000 kilo, about 30 weeks of gestation. Unfortunately, the baby delivered by bad upper score and they got respiratory distress and need intubation for respiratory distress. And they stay in mechanical ventilator really for a longer time, more than 5 to 6 days. He shows some improvement and they are planning to wean for possible extubation within the first coming hours. But unfortunately, the sister noted that the baby is behaving not like before. He is a bit lethargic and not moving and not crying like before. And even she used to start for him trophic feeding. Trophic feeding, I need a very small amount, like 10 ml per kilo, 10 to 20, and increase gradually. But even he cannot digest it and found the residual the same as given. She gave him 3 ml, and the residual also is 3 ml. So what can be the organism?
So for this case, my provision would be the late onset sepsis. So the possible organism can be, first one, I would like to rule out Staphylococcus aureus infections.
Which type of staph?
It can be
Cons.
cons.
Yes. For gram negative.
And gram negative, it can be so, pneumonia.
Escherichia coli. Okay.
Pneumonia, and can be also Pseudomonas, considering the healthcare associated infection as well.
So now we must ask about the antibiotic profile of the area which you are working. They will tell you the most common organism present, okay? And it will help us to choose our upgrading of antibiotic. What's your intervention now?
So first, early stabilization of the patient.
Okay.
So managing the ABC, and then give early treatment of antibiotics. And before that, take a blood culture.
Okay.
And then when the blood culture result come out, change the antibiotic accordingly to the organism.
But the most important is close monitoring for every system.
Okay.
It is very important. Okay. The last question about.
How about the feeding?
Sorry?
Because from the case that you give early, is it there is a inadequate feeding?
Not inadequate feeding. There is residual. It means that the child cannot tolerate feeding. Usually, we are going to start total parenteral nutrition as early, even from the first day, if we can, for that child, and try to build up the feeding gradually. Of course, this situation, we are going to consider even vancomycin or more stronger antibiotic if needed. Okay. Some specific infection we speak about, like varicella, if the mother came just 2 days before delivery with a rash, which is a doctor see it is varicella zoster, and he send the IgG and the IgM of the mother. Okay, what you will do for the baby?
Sorry,
another
Last treatment.
another student. Now the mother has got rash, looks like chickenpox, just 2 days before delivery. Okay, and the baby now delivered. What's your action?
I think can I try, Prof?
Yes, please.
I think in view of the development of rash by the mother 2 days prior to giving birth, so I think I need to rule out one of the important differential of chorioamnionitis. So I would need to do a high vaginal swab to see the type of infection. But I think most likely it will be E. coli, and I would treat that off. Especially if on top of having the rash, if the mother have like foul smelling discharge during giving of birth, so I think it's important to rule out chorioamnionitis.
But the mother has no history of chorioamnionitis. She has only
History.
of some fever and rash, looks like a chickenpox.
Is it herpes simplex?
Oh, chickenpox.
Yes.
VZIG, Prof. We need to give acyclovir IV and also the varicella zoster IG, immunoglobulin.
Yeah, this is the most important, is the prophylactic. If the baby is stable, we are going to consider give him VZIG, okay, directly after birth, and they advise to do as soon as they can. Sometimes it is not available. We can tolerate up to 96 hours because it is very dangerous. Varicella can cause life-threatening either CNS infection or severe pneumonia, okay? So at the time, the VZIG is the gold standard, and put the baby under observation for any manifestation of sepsis. We are going to start a acyclovir or according to the consultant opinion for this follow-up, okay? But we must know that we have some preventive medication like VZIG for varicella, and we have also, if the mother have got hepatitis B, it is better to give the baby 2 things at the same time, but at different place. The vaccination for hepatitis B in one leg, and the hepatitis B immunoglobulin at the other leg. Okay, is it clear? And please, it is not good at all to the mother. I have recommended already said that she has hepatitis B, and no one considering to give her the hepatitis B immunoglobulin unless the treating physician stated that the infection is very minimal and the load of the virus looks not to be trivial, maybe no need. But the gold standard is to give unless ruled out by the senior staff, okay? An important point also for working in any unit, you must respect the protocol which is going in your unit. Don't sit and say, in that hospital in UK or USA, they are doing something like that. No. We have, alhamdulillah, a good protocol, pediatric protocol. We have a lot of cases of neonate already put protocol for that. And if your unit are completing her protocol, don't breach the protocol. But if you need to negotiate, you can speak for the senior for that. But the gold standard is to go through the protocol, okay? Because sometimes the protocol is covering more than one patient. It is covering all the system and all situation. Okay, this one early onset and late onset, you must be able to answer what is the difference. Okay, here is a clinical spectrum of sepsis, usually in infants and neonate. It can be just localized or systematized. It can be severe, but it can progress to septic or multi-organ or this. It is very dangerous. What is the SIRS? I hope during your presentation, if you can give me a case about COVID-19 infection in children, please. The one who will do that, I will give him a favor. Okay, so please, I need to hear one presentation even in the differential diagnosis. This is severe respiratory. What is the SI severe respiratory symptom, which is considered 2 of 4, 2 criteria of the 4, okay, which must be abnormal temperature or abnormal leukocytes. It is very important in the neonate, but I'm just in infant, but I'm just trying to consider that temperature, leukocytes, tachycardia, and respiratory distress. This can progress to severe, then can be septic shock, in spite of you are giving 1 or 2 bolus. If the patient still hypotensive, okay, you must consider him in a septic shock. He needs rapid treatment. Otherwise, as you know, septic shock can be compensated or uncompensated. What is the difference between compensated or uncompensated? What is the difference between compensated or uncompensated?
Compensated, the body has still the hemodynamical stability, whereas in the decompensated, the hemodynamical stability is lost. So it depends on the vital sign and other parameters to differentiate between those two. For example, if we talk about the respiratory rate, so for those with compensated shock, there will be tachypnea, but for the decompensated shock, there will be either it can progress to small breathing. Same goes with other parameters. For example, talking about the pulse rate. So for the compensated, it will be more than 120, but it is the good volume. Whereas in the decompensated, there will be steady pulse, but more than 120 beats per minute, and so on with other parameters.
Yeah, that's why I used it to say mainly the blood pressure and respiratory and the heart rate. If you picked it early while they are stable and the patient has signs of sepsis, so you are treating him now at the stage of compensated shock. So your treatment will be very, very, very effective. If you left him until he became decompensated, I mean the blood pressure became low and the heart rate became to be very high, at this situation, it can be uncompensated, which sometimes it cannot be saved. Facility care, this is another lesson of early intervention, please. Early intervention. If you are in care of patient, care him as if he is one of the most lovely person to you, please. There is some WHO prediction of severe sepsis. It is a nice article. I'm just trying to say that, but at the end, I'm trying to remembering you, please, how the infection can come to this very weak infant, and your goal is to prevent it. Thank you for your attendance, and now it is your role to ask, and I am welcoming to answer for any question.
Prof.
Yes.
Prof, sorry, Prof, I have a few questions. First and foremost, with regards to the immature to the total neutrophil count, the IT ratio, my question would be that what is the cutoff value for us to diagnose sepsis? One. The second question would be how do we actually calculate the immature and the total mature and plus the immature neutrophil, Prof?
Yeah, this is another important communication with our auxiliary staff. Like you are going to send it to lab, you must be clear. I need to complete blood count, including blood film and the inflammatory marker. They will answer to you, and they will put for you according to every age, the premature, how much for the term, how much for the infant, how much is the suspected. So this is important point which I usually advise to consider the peripheral blood film in any case of infection or even in any case of malignancy. Some of our colleagues has an elder child and is diagnosing him as possible ALL. Okay, what is the investigation? Full blood count. What else? He will remember at the end the importance of peripheral blood film just for looking for blast cell. Here you are looking for some marker of infection, which is the lab can guide you. Okay, and you'll find at that point what is the normal written in front and beside you. This is the patient result. This is the normal result. Okay, I don't want to overwhelming you, but some numbers which is not recommended for you now. Inshallah, you will remember it when you start the practice. Am I clear? Good communication with the lab, with the RAD, what about your requirements, and so they can help you in the optimum.
Yes, Prof.
Okay.
Doctor, I have a question. Previously that you said blood culture have a low rate of positivity. So, for example, in the case of a patient that having a clinical suspicious of neonatal sepsis, and we already send for blood culture and also start our empirical antibiotics. But after about the 36 or 48 hours, the blood culture result in negative. So at that point of time, should we repeat or should we try to find another causes?
Yes, this is a very important. If you go through the WHO or other presentation for that, there is a lot of detail. If the patient is clinically stable and the risk factor is not so severe and the culture came negative, some advice to cut the antibiotic. But if there is still symptomatic or some parameters are high, like CRB is still high, okay, we may extend it to up to 5 days. If the culture give you a clear-cut infection, you will go through it. Is it just like GPS? They can consider like 7 days. If it is gram-negative, it can be 10 to 14 days. If it is meningitis, it can, as we speak before, it can be up to 2 to 3 weeks. But the gold standard is
we extend the empirical.
Yeah, if the patient is stable and the rest and no clinical signs of sepsis and all parameters like CRB or procalcitonin is negative and the culture is negative, go ahead and stop and follow the baby. Even sometimes if the mother, like we are speaking about BROM, premature rupture of membrane, usually you must consider 2 factors, not 1 factor. BROM alone, sometimes they will tell me this mother has BROM for 24 hours. Really, she has a partial coverage, just came before delivery by 2 hours, not 4 hours, and given the first dose, but she has no fever. Her investigation white count is acceptable. Her CRB is okay, urine is free. So my goal here is to ask for full blood count, and if I'm afraid, I will put the blood culture. Okay? And wait, without antibiotic even. The issue is not the antibiotic alone. The issue is your ability to evaluate the baby and see he is in need of any support or not, if you need to continue or not. Because if you continue antibiotic without limitation, you will give him infection which is multi-drug resistant or fungal because of abuse of antibiotic. So you must stabilize the baby by antibiotic, but you must stop it once you feel the situation is completely assuring.
Doctor, if the patient remains symptomatic, is there any maximum trial of antibiotic that we should give the patient?
Any what?
There is any maximum trial of antibiotic if the patient remains symptomatic regardless of the previous antibiotic treatment that we give to the patient?
I cannot understand your question.
Means that if the patient remains symptomatic and we extend the empirical antibiotic, but just like you said just now, we can change the antibiotic according to the clinical suspicious of infection. But if the patient remains symptomatic is it there is any maximum trial of antibiotic?
If it's still symptomatic, we will extend it to 5 to 7 days mostly. If asymptomatic, we will stop at 48 hours of culture. If it's still symptomatic, okay, or the investigation is not assuring, we may extend it to 5 to 7 days. Because really the final blood culture will come after 5 days. We are asking for the preliminary. Preliminary is stable, stop. But if there is any suspicious, like I found the CRP is high and it doesn't dropping, so I continue. Some are recommended for CRP sepsis to be given about 5 days antibiotics, even it is only CRP positive.
Yeah.
Okay.
Okay, Doctor. Thank you, Doctor.
Prof, I'd like to ask a question. In regards to the investigation, just now Prof said that we need to do all the culture for the different system because we want to rule out any form of multi-organ failure, multi-organ involvement of the sepsis. So like, is it like based on the clinical history of where it is more likely to be the source? As in like if it's UTI, we tend to do only, we do the suprapubic urine collection, or we just do for the whole system?
No. We are the gold standard is to do the blood culture, the formal blood culture. But if we suspect specific, we are going to check if we need for fungal, if we need for viral. But usually we are doing is just a general blood culture, and we can specify if we need aerobe or anaerobe or like that.
Oh, I see.
Yeah, you must be guided by the history and the situation. Because what is this? We mustn't also wasting our resource for just a blanket investigation for everything. If the patient is clear cut, he looks like simple sepsis like that, no need to go deep for the other. If just starting now, no need to consider like go deep for fungal like that unless we have suspicious. But initial blood culture, okay. If needed after that, we can comment another.
Okay, right. And then second question, Prof. Just now Prof mentioned that the best the golden standard for investigation of UTI is suprapubic urine collection instead of catheter because it is more sensitive, Prof.
Yeah, I mean the sensitivity and the specificity is very high for it. It is a gold standard really, but some community accept and some community refuse. And if you went to some like European area, you will find them are acceptable. Some area they said, please, we can use catheter. It is a less traumatic for the baby like that because it depends. At the end. I feel that, and thank you for your question because I found many stuff. Do your job as a routine. That is to say, they will come to the mother. Hi, mom, your baby looks like have UTI. We need to do the test for suprapubic. We just put a needle and we'll insert here in the lower abdomen to get few centimeter of urine, because if it is infected, we will make sure. The other one which you put collector like that, it is not enough, mom. So the mother good panic. To the same story in my unit before. If my junior colleague fail to convince the mother for important procedure like lumbar puncture. Lumbar puncture, we cannot diagnose meningitis clinically alone unless it is complicated meningitis. Because we can make him only with fever. And if I suspect late onset sepsis, okay, and wait until he started to get convulsion or a good signs of CNS infection or like that, it will be very traumatic to him. So some making our rule to just tell the mother, your baby needs this one. And the mother said, I am panic. He doesn't try to decrease her panic or tell her the complete story. That's just tell her, Mom, I would like to tell you something. Sorry, we have two types of fluid. One from front, which is the urine, and one from the back, which is the CSF. This fluid has no relation to the blood. I mean, if I did blood, sometimes it have no indication that I have UTI or I have CSF infection, and I must get few drop from that one. The same, I cannot substitute this one. And the mom, it is very important to know, because if proven meningitis, I need to give up to 2 weeks or 3 weeks. Okay, and if unproven, I will start the treatment within 2 to 3 days. So no need to prolong the issue. So it is very beneficial to your kid. Otherwise, I will keep him in the hospital for up to 2 weeks, giving him antibiotic because he refused. It may be you go your home early. She will tell you then, oh, I'm afraid. Some tell me, or I show in the media that some babies got paraplegia. Mom, this is just rooming. We are doing it every day, Mom. And if it is my baby, you see how we must be sympathized. I swear, if it is my baby, I will do that. If really the people can feel the pulsation of your heart, if you have a warm heart with them, if you are sympathized with them, you are seeking the benefit for them, they will follow you. That's why I will ask the junior staff, please try to convince. And if he failed, he must contact the consultant, and he will come to himself try to convince the family. Of course, there will be some people at the end very aggressive, you cannot convince them, but there is